Hello everyone. My name is Iman Khwaja Reddig. We are pleased that you could all join us for this week's lecture in Volume 10 of our No Neuropsychology Didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. One of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audiences. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. No Neuropsychology collaborates with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through AAPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our YouTube channel later this week. Now, it is my absolute pleasure to introduce my dear friend and incredible colleague, Dr. Bruna Schneider, for today's lecture titled At the Heart of It, the Neuropsychology of Congenital Heart Disease. Dr. Schneider is a clinical neuropsychologist at Cincinnati Children's Hospital Medical Center with expertise in neuropsychological assessment of individuals with congenital heart disease or CHD. These conditions, while inherently related to the anatomical structure and function of the heart, can impact brain development and have lasting consequences for how an individual thinks, feels, and interprets the world around them. Her approach to patient care is deeply personalized, recognizing that each patient's needs are unique and best understood through direct engagement and thoughtful inquiry. Dr. Schneider's professional journey is driven by a profound curiosity about the brain's functions and how its intricate mechanisms influence individual perceptions of the world. This curiosity was further ignited by her experience as a mother, which deepened her passion for understanding the brain-heart connection, particularly in children with CHD. Recognizing that more adults are living with these conditions than children, her clinical work and research now naturally extend to following these patients throughout their lifespan, providing continuous and informed care. As a multilingual Latina, she also aims to always be culturally sensitive to her patients' needs and is committed to providing comprehensive care that respects and incorporates diverse backgrounds. Dr. Schneider completed her graduate training at Albizu University, internship at Jackson Health System in affiliation with the University of Miami Miller School of Medicine, and neuropsychology fellowship at Akron Children's Hospital. And with that, I'm going to turn it over to Dr. Schneider.
Thank you so much, Dr. Reddick, for that introduction. That was great. It is always weird to hear so much about yourself, but it is great to get started. Okay, can you guys see my screen okay?
Yes, it looks great.
Wonderful. Okay, so yes, as the name suggests, we're going to be discussing a lot about congenital heart disease today, what that means. Some neuropsychologists are very familiar with this, some are not. So the point of today is to give you a little bit of an introduction and go on from there. So naturally, I have no disclosures for today. And I do want to say, first and foremost, thank you for the opportunity to be here. It is truly an honor, and I am beyond excited. As you see, the heart and brain are prominent in most of my lectures, and in my office, you'll see my patients love to play with my heart and brain models and plushies and all these things. It's a little bit of an obsession that really started with the heart and brain comics, which we'll get to. You'll see that at the very end. So the goals of today is to talk about congenital heart disease or CHD types. We'll talk through diagnostic methods and treatment, understand neurodevelopment and neurocognitive aspect of this, understand the adult side of it, figure out how is this managed, What are the research groups and collaboratives doing? We'll talk specifically and highlight the Heart and Mind Wellbeing Center here at Cincinnati Children's, where I have the privilege to work with my colleagues there. And then we'll talk through future goals, particularly my own research goals for the near future. So we'll start with what exactly is CHD. So CHD stands for congenital heart disease. Sometimes you'll see in the lecture the word disease be replaced with the word defect because it is literally a defect in the heart, but widely accepted and agreed in the field that disease is the better word, if you will. So like I said, it really is describes a defect that's based in the heart's structure or the heart's function. Now, it can be categorized in many ways. There's lots of different types. So we can think about it in terms of severity. We can think about whether it limits oxygenation. So if anyone's ever heard of the word cyanotic, that really refers to sort of that bluish appearance and usually the lips, the fingers, the skin, and that can be related to a lot of times CHD. Different types of them cause cyanotic problems. Some are not. So you would see the non-cyanotic. Or we can categorize these conditions based on the problem they create, meaning whether it causes too much blood or too little blood to pass through the lungs or to the rest of the body. Some of them are random and there is no genetic association with it, but a lot of them are, there's a genetic component or it can be chromosomal syndromes, and more often than not, those tend to be more severe and we'll see more consequences as a result. So we'll get to those in just a brief moment. So we'll start with some basic facts. So around the world, about 1.35 million babies are born each world with heart disease. About 25% of those kiddos will need some sort of, when it says intervention, it's really talking about surgical intervention during the first year of life. Many, particularly in the more severe side of things, may require multiple surgical interventions and even heart transplantation at some point in their lives. So those are things to certainly think about. A lot of research goes into cancer and understanding sort of the neuro-oncology side of things for children, and that is absolutely fantastic. But just for thinking about basal rates and sheer number of kiddos, for every one child that is diagnosed with cancer, there's about 60 children with congenital heart disease. So it is not common, if you will, but it's also not uncommon. Now, survival rates have gotten significantly better over the years. Many years ago when all of this started, really the focus was, how do we keep these kids alive? How do we get them past their first surgery, past a few hours of life? Then how do we get them past their first year of life? And now, as you'll see in a little bit, the vast majority of them are surviving well into adulthood. And vast majority is in the 90%, right? A lot of times, long time ago, CHD used to be almost a death sentence. This is back in the 50s and 60s. Now it's something that you can very much live with so long as you have the appropriate intervention. Now, before we talk about what happens when the heart malfunctions or when something goes wrong, we have to understand how the heart functions naturally, how it's supposed to function, right? And so the heart is broken down into 4 chambers. You have the right atrium. Let's see if my pointer works. Hey, okay, there we go. So you have the right atrium up here, you have the right ventricle, you have the left atrium and the left ventricle. All of these chambers are extremely important. They all play a role in how blood circulates through the heart. Now, if anyone is, and I'm sure many of you have administered the WAIS before. Now, the Wechsler scale for adults, there is that infamous question, at least in my world, in my side of things, the infamous information question about name 3 blood vessels in the body. Whenever I ask this question, since the WAIS very much belongs in my battery for my adult patients, name the 3 blood vessels in the body. All of my patients, whenever I ask that question, tend to smile because they know that question all too well. Those being the veins, the arteries, and the capillaries. The arteries being any vessel that transport blood away from the heart and onto the rest of the body, the aorta being the most famous one, or the biggest one. And then the veins, they're transporting blood to the heart, away from the body, away from the pulmonary or the lungs and all of that. And the biggest one there being the vena cava. We'll talk through all of that. Now, the lesser known one is the capillaries. And when I first gave this presentation many years ago, and I was still a fellow, I made a lovely joke that the capillaries tend to be the interns and fellows of the heart and the body, mostly because they do all the work and they often don't get the name and fame associated with the work. And that is still true to this day. And so essentially, you'll see here on the next slide how this works. And so blood comes into the right atrium from the superior and inferior vena cava. Then that goes into the right ventricle, then to the pulmonary arteries, then away to the lungs where they picks up the hitchhikers known as oxygen. They come back through the pulmonary veins into the left atrium, to the left ventricle, and then into the aorta to the rest of the body. So blue meaning the non-oxygenated, red being the oxygenated blood that we see there. And so what are some options or some things that could happen, some types of congenital heart disease? Now, when we think about the blood, the problems that cause too much blood to pass through the lungs, we have ventricular septal defect and atrial septal defect. These can be fairly often seen. They tend to be more milder, if you will. I'm not particularly fond of the term mild, mostly because for families, none of it is mild, right? Having to have surgeries does not make it mild by any stretch of the imagination. Can have lots of, from a family standpoint, it's really scary and worrisome to put your infant, sometimes days old, through surgeries and things like that. Now, sometimes VSDs and ASDs can close on their own. Even when children are born too soon, they might have what's called a PFO, and that is essentially another hole in the heart that tends to, more often than not, around the vast majority of the time, close on its own and not require any surgical intervention. Other types of these include the PDA that you see there, or the patent ductus arteriosus. And this simply means that there's a connection between the two arteries, pulmonary artery and the aorta. And when that happens, you see that purplish blood, that combination of the two. Then some examples of problems that cause too little blood to pass through the lungs. We have tricuspid atresia. Anytime you see the word atresia, means that there's either a narrowing or completely absent type of valve or something that's missing. So in this case, there is the valve there is not, or the tricuspid valve right here is missing altogether. And so in order to compensate for that, the heart will cause these other openings, the VSD and the ASD, to get the blood flow to still go through. It's not the way that it's supposed to be naturally, and so you get an underdeveloped right ventricle and lots of other complications. But I think perhaps the most common form of this type of category is the transposition of the great arteries, or TGA for short, sometimes known as dextral transposition of the great arteries, so DTGA, but it's essentially the same problem or issue. And it essentially means that the aorta and the pulmonary artery are completely reversed, meaning that they're connected to the incorrect ventricle. They should be backwards than what you see here in the picture. And so as you can imagine, the blood flow is not going accordingly. And so we'll see during surgery, they'll switch these around. Then when we think about problems that cause too little blood to travel to the rest of the body, it usually involves some sort of issue with the aorta. Now, that could be an aortic valve issue where that is either completely atretic or there's a narrowing. There could be the aorta itself is narrowing, or what we call a coarctation. Or the most common form of this is the hypoplastic left heart syndrome, which includes sort of multiple issues and multiple difficulties that essentially cause the left ventricle to be underdeveloped, hence the name hypoplastic, and the right ventricle to sort of overwork as a result, and lots of surgeries are required to sort of correct this issue. Now, you'll also see in the literature a lot of times the term single ventricle CHD, and this really refers to any disorder that causes particularly impact to any one ventricle, meaning that only one ventricle is truly functioning. Like I said, that hypoplastic left heart syndrome is one of the more common ones. Tricuspid atresia is another, because then the right ventricle isn't getting enough of the blood, and so it's overworking, and so it becomes very muscular and sort of thick and difficult to work through. And pulmonary atresia is sort of the same, just on the other side of it. Now, as neuropsychologists and trainees, we talk until we're blue in the face about MRIs and CT scans and cerebral angiograms and all these things that are important for us to understand neuropathology and how that translates to neuropsychological functioning, right? Now, it's also important when we're thinking about CHD to understand what are some diagnostic methods from that front, right? There are cardiac and CTs and MRIs. There are blood tests. There are cardiac angiograms. But I think two of the biggest ones that you'll hear is echocardiogram or electrocardiogram. So electrocardiogram, often referred to as EKG or ECG for short. And this is essentially measuring of electrical activity, much like an EEG would. It measures the electrical activity of the heart. Tells you how quickly, whether we're experiencing tachycardia or bradycardia, that's quickening of the heart or slowing down of the heart, and gives us a lot of great information. But more often than not, the most prominent one you'll see is the echocardiogram. And this is essentially an ultrasound of the inside of the heart. It helps us identify any structural, and when I say us, I mean cardiologists. I do not interpret any of these, but they are pretty interesting to look at. And they can identify, like I said, any type of structural defect or any issue can even be done in fetal monitoring and that sort of thing. Now, when we think of treatment options, at the very sort of lower end of severity, more, again, milder form of CHD, sometimes it can be just simple monitoring. If the ASD or the VSD close on their own, then that could just call for some follow-ups with the cardiologist. Sometimes it includes some pharmacological interventions, like you often see in kiddos and even in adults, the prescription of aspirin, either baby aspirin or full aspirin or things like that. There's changes in terms of diuretics and beta blockers and ACE inhibitors. There's diet and lifestyle, changes, exercise restrictions, that sort of thing. Then there is a cardiac catheterization, which is essentially, as I'm sure you're familiar with, placing a catheter into the leg through a large vein in the leg to then help guide something into the heart, whether that be to a balloon in terms of coarctation of the aorta to sort of open that up and create a stent, or it can be just simple, but other types of balloon dilations and things of the sort. A lot of times these types of interventions are considered non-surgical because often they can be done in the outpatient setting, don't require, prolonged hospitalizations or anything like that. And then we have naturally the surgical interventions that are any types of repairs or more named procedures. So when we think of those, we have, and a lot of times as neuropsychologists, you're probably wondering, why do we need to know this? Why is this important? And my fellows will very much tell you that I am a stickler for understanding these procedures, even at the very basic level, and understanding the order with which they need to occur for any given child, simply because it really helps us understand what the child is going through and what are the possible complications. And more often than not, helps us communicate with cardiology. We always want them to understand what we're saying and reading our reports. The same thing is backwards, right? We want to be able to communicate with them and understand what they're talking about. So you often see some sort of insert a CHD name here repair, whether that's atrial septal defect repair, double inlet left ventricle repair, what have you. That can go for just about any of them. Then there are named procedures that were named by the creators of the procedure, the cardiothoracic surgeon that created them and identified them. So the Blalock-Taussig or BT shunt is usually one of the first ones that a child would go through, or the Norwood procedure. These tend to occur very early, as little as few days old or even hours old. The Ross procedure is another one that you see. And then the Fontan operation, you see that little asterisk there, mostly because this is a big one. And this is one, not every CHD requires this, but the ones that do, there is a lot of extensive monitoring and sort of following along with the patient. Once they're between two surgeries, whether that be, there's also a Glenn surgery that's not listed here, but if they're between sort of a Glenn and a Fontan operation, they're known as that interstage level, and there's certain requirements and things that they need to be monitored for. Then after the Fontan, it typically occurs around ages 3 or 4. Then there's lots of other complications that we have to think about. There's something known as a Fontan liver, or things that sort of side effects or sequelae, if you will, of a Fontan operation. And so with all of that, what do we understand about neurodevelopment and neurocognitive impact of a CHD? Early on, and I've had many patients tell me, my cardiologist told me I was cured. Why do I need to talk to you? And yes, while the defect itself might have been repaired, I think cured is not the best word, but might have been repaired. there is still a possible impact to the brain, right? The heart and brain are very much connected. If there's not enough brain blood and oxygen flow to the brain, then there can impact, have significant consequences to brain development. The brain, I always say this to my families, is very small relative to the rest of the body, right, in terms of percentage and weight, but it is very needy. It requires a significant number or significant amount of blood and oxygen, and it requires it constantly. Other organs have the ability to hold on to that energy source, that glucose, that blood, if something were to happen where it gets cut off or the supply, diminishes in for whatever reason. The brain, as smart as it is when we think about from a metacognitive standpoint, if you will, it's not very good at doing that. It absolutely has no capacity to do that whatsoever. And so when there is that cut off, like a hypoxia or anoxic event, there can be some immediate consequences. When in a CHD is less so of an anoxic or hypoxic situation, but more of a constant depletion. And so the brain needs to develop at this constantly lower level than what it would want. And so when we're thinking about the impact, we have to think about patient-specific factors and then procedure-specific factors. Patient-specific factors are the ones that we really can't change. That's the type of severity or the type or the severity of the CHD, whether it's genetic or not, whether there's other complications during birth, like prematurity, low birth weight, other comorbidities like microcephaly, male gender, not a comorbidity per se, but a factor, Caucasian, ethnicity, whether there's any other prenatal complications, the family environment. So these are one side of the coin. On the other side of the coin, we have either pre-surgical, perioperative, or post-operative parameters or things that we consider, whether that be how long it took for surgery to occur, what happened during surgery, were there any complications requiring something like a bypass or other, extra blood being brought in. And then post-operatively, we have to think of certain things that are required a lot of times for survival, things like ECMO or extracorporeal membrane oxygenation, which essentially pulls the blood out of the body and into this machine that acts like the heart and the lungs. It sort of aerates it, gives it some oxygen, and takes it back and pumps it back into the body to help. Now, it's a great service in that it's life-saving, but it can have some complications from a cognitive standpoint as well. And then, like I said, in terms of genetic syndromes, there's a lot of syndromes that can be associated with CHD. I think one of the most common ones that we'll see is that deletion 22q11.1, which is also known as the George syndrome, Jacobson syndrome, Noonan, Turner, Down syndrome. These are all syndromes that we can see have some sort of cardiac impact or cardiac difficulty. Some on the, again, more milder or less problematic side, and then some more severe and significant impact. When we think about sort of where where did they fall on that severity spectrum, on the milder, again, not a huge fan of it, but on the milder end of it, there's really not a really small percentage of patients where we would see more severe impairment there. Doesn't automatically mean that if I see a child with VSD that I would say, nope, I don't expect to see anything. No, it's always possible, but it's less likely. Whereas with the more syndromic or genetic presentations, those are much more likely to have even mild or even more severe impairment as well. This is an illustration that was put forth by Dr. Phillips and Dr. Kasparian here at Cincinnati Children's, who is essentially my boss, and she's fantastic, talking about neuroimaging in congenital heart disease. What types of imaging are we looking at in terms of considering how it impacts the brain and sort of that relationship? For this particular study, they looked specifically at individuals with transposition of the great arteries, mostly because that is one of the more severe and more common ones that we will see. And this is just half of the infographic. We'll get to the other half in just a little bit. But as you can see, there's lots of studies being done on all different kinds of neuroimaging to sort of help us understand what is going on and what can we expect. Now, when we think of the relationship between the heart and the brain, we have some idea. There's no exact we can't speak exactly to what is the exact trajectory that happens that causes possible brain impact or difficulties, mostly because we don't see it in every patient. And this is something that I'll say over and over. what we see in research doesn't automatically translate to clinical work. But one big theory is there is some evidence to suggest that there are structural and hemodynamic characteristics of the different CHDs that lead to changes in the autoregulation mechanisms in the brain, essentially to protect it from hyperperfusion or hypoperfusion and hypoxia. And in order to do that, it does vasodilation of the cerebral arteries. It increases the diastolic flow and decreases the cerebrovascular resistance, but prolonged periods of that. So that's what the brain does essentially to protect itself from any issues. Prolonged periods of that, like I said, it's not one big acute event. It's a prolonged, milder form of anoxia or hypoxia, if you will. This can lead to delayed maturation of fetal oligodendrocytes, reduced myelination, and significantly increased neurovulnerability. And so when we think about this, we're thinking of CHD, essentially a lot of the brain disturbance consists of white matter injury. There is some research to suggest that the right hemisphere is more vulnerable than the left hemisphere, much like the still developing frontal lobes are more vulnerable. We can sort of speculate as to why that occurs, but it's sort of what the research is suggesting at this time. And then when we think about the more severe cyanotic CHDs, a lot of times research finds less mean cerebral blood flow, particularly in occipital white matter, the basal ganglia, and the thalamus. And then we also have to think about the anesthesia impact, especially at an early age, and what happens when we need to do it multiple times throughout the fetal period or the neonatal period, if you will. This is just another infographic that looks at more of sort of the timeline with which we can see, what are some factors at each different age point. Again, the innate factors or the patient factors versus the environment and operational side of things. And then what are some of the images that we can see, and what are so far what has research shown can cause in terms of positive neuropathology. And then this shows the different possible areas that can be impacted and what that means at a fetal stage, at an infant stage, at a childhood stage, and then later on. As you see, we don't know as much from the adult side. I'll say it again in a little bit, but a lot of times the adult research is not longitudinal. We don't see sort of that long-term impact on any one patient. It's more cross-sectional, if you will. But it's important for us to have that understanding at a very basic pediatric level as well. Now, there's other factors to consider also. Pain. At one point, it really was believed that infants felt no pain. And so as wild as that may be, surgeries were conducted without any analgesic events or numbing agents, if you will. And that's just crazy to think about these little babies going through open heart surgery with nothing. Nowadays, obviously, there's lots of these options, which is a good thing. But even now, even with all of this, neonates experience more than 300 painful procedures during your average hospitalization. And that is wild to think about. That is a lot of pricking and prodding and this sort of exam, blood tests, and all of this. And that can be painful, especially to an itty bitty who cannot express that. Now, repetitive exposure to pain has been associated with altered brain maturation, white matter alterations, smaller thalamic and cerebellar volumes, and then naturally alterations in pain processing, pain sensitivity, that sort of thing. Now, the alternative is not that much greater, if you will, from a cognitive standpoint, how it impacts neuropathology. It's great in that the children are not experiencing the pain. I think that's barbaric, but it can have some disadvantages, right? It's absolutely necessary, but it's a evil that is a necessary evil, if you will. It can have lots of neurological or neuropathological side effects. Now, functionally, what does all of this mean, right? From an early developmental standpoint, and we will not go through all of these, but from an early developmental standpoint, I think the biggest thing that gets impacted very early on is gross motor skills. That being because a lot of times there's prolonged hospitalizations, there's restriction in how much movement a child can go through. And so they're bedridden sometimes, they're in a lot of pain and experiencing sometimes complications. So because of that, we're more likely to see gross motor delays early on. A lot of times once those factors get removed, kiddos tend to catch up from a gross motor standpoint, but we can also see other types of delays, other difficulties. And as they get older into kindergarten and school age and adolescence, young adulthood, we can see some difficulties. And so when we're thinking about that school age group, the adolescents, not the adults yet, but when we're thinking about that isolated group, there's an increased risk for deficits in processing speed, language abilities, nonverbal reasoning, memory, attention, executive skills, all of those things. Now, we don't like to speak to a particular profile, in that there is no cookie cutter. We're going to see this with every child. I don't think we can say that for any neurological condition or any condition that we treat as neuropsychologists, right? There's never going to be a direct one-to-one between what research is telling us to expect and individual experiences, which is why it's important to look at the patient in front of you. And just because there's an increased risk for something doesn't automatically mean that this is going to happen, right? Again, just different ways to consider possible risks. And so again, this is that infographic again, but you'll see the full thing here, and where it's really identifying, based on this neuroimaging, the different areas that can be impacted from a cognitive or neurocognitive functional standpoint. You'll see the gray ends there, particularly this older age area where it's grayed out, and that's because there really hasn't been a whole lot of neuroimaging studies on adults, especially from a longitudinal standpoint. And so the information listed here is glaringly missing. Something that you'll see that's also glaringly missing is mental health conditions. Where are they? Why aren't these neuroimaging studies focusing on them? And we'll get to that in just a second. So there is an increased risk for autism. There was recently a really giant CHD community conference last year known as the World Congress, pulled out people from all over the world. I had the great honor and privilege to get to go, and it was a fantastic many discussions with all these interdisciplinary groups, and it was a great experience. But one thing that I came away understanding, it was glaringly clear, is that autism is a big piece and something that we are often missing. In CHD, for whatever reason, a lot of times the signs aren't very obvious, especially early on. And it isn't until children are starting to get involved in sort of those teenage difficulties and require a lot of that, social cueing and understanding those intricacies, that's where we'll start to see more of the difficulty pop up. And so this provides some significant diagnostic challenges. And then we also have to think, more recently, the research has started talking about adaptive functioning. Very early on, there really was no consideration of this whatsoever. So this is a great published work by Dr. Tan and his group, and Dr. Ilardi, Dr. Tan and Chalk and Dr. Ilardi at Choa. And really looking at what are the possible strengths and weaknesses for these adolescents from an adaptive standpoint, and why it's important for us to talk through it and figure out ways to help them cope with it. Now, as medicine improves, so does life expectancy, right? Earlier, I said that around 90-something, the exact number is 97%. Didn't want to spoil anything, but around 97% of children born with CHD are expected to reach adulthood. Now, this particular graph shows quite old data, but it really just paints a picture of how many more individuals are surviving from, versus from 87 to 88, just that 1 year, versus between 2004 and 2005. We're seeing a lot more individuals in their 80s, sometimes individuals even in their 90s, which is a significant improvement. With that being said, around 70 or more % of these individuals are not being monitored by their appropriately specialized provider. And what that means is, when we're thinking about CHD, there are specialized cardiologists, as you would imagine, that manage these conditions. And once the individual turns into young adulthood, 18, around that age, they talk specifically about, hopefully younger, but by then we'll be talking about transitioning to adulthood and turning into an adult provider. Now, an adult cardiologist that sees individuals with these conditions is not the same as a cardiologist that sees adult patients. So an adult cardiologist that sees heart disease and more of those acquired conditions is not necessarily well suited to see the CHD types of problems. The problems are vastly different. The sort of monitoring management is significantly different. And so they need someone who is an adult cardiologist with who specializes in ACHD. And when we think about just general percentage of individuals with the condition, so back in around 2020, 2014, 2016, there was an estimate of around 2.4 million individuals with CHD in the United States. Of those, and this is a slide I was very proud to make, this took forever, but of those, around 33% of those individuals are in the pediatric realm, so kiddos, versus around 1.6 million of those are adults. Now, this is a wild statistic to think about, considering that this is a notoriously pediatric condition, right? When we think about congenital things, we're thinking about early on, but now there's more adults living with the condition than there are children living with the condition. And so we have to sort of cater to what are their needs. And the research has been now shifting into focusing on how do we help them and how do we get them whatever assistance they're going to need, particularly because a lot of times these adults didn't get the monitoring, the management, the care in the pediatric side, especially from the neuropsych standpoint, right? There was no standard of care of following these patients. The earliest patient I've seen was 9 weeks old prior to the second surgery, and to monitor developmental impact. And you say developmental impact really loosely at 9 weeks old, right? But these kids are now followed much more consistently across their childhood until around age 18 or early adulthood, when pediatric neuropsychologists will no longer be available to them. But then after that, what happens? There is nobody seeing them. I'm now seeing them, but there's a significantly fewer people seeing them. And so these adults didn't get that trajectory, didn't get that experience. So now as adults, they're saying, why now? And we'll get to that towards the end of the presentation here. But what does this mean? What do we know about adults with CHD? There's not a whole lot that we know from a trajectory standpoint in terms of neurocognitive outcomes, right? Like I said, there's cross-sectional research that looks at adults, that looks at children, that looks at infants, but we don't yet really have anything that follows one particular patient or a group of patients throughout their entirety of their lifespan. And that will take some time to be able to get there. But that's a problem for now, because it means that we don't really understand some of this trajectory. And so our goal as the ACHD world and the field is really to find out. But still, something is missing, right? Something that I said was glaringly missing, that the authors pointed out was glaringly missing in that infographic, and that being mental health, right? There is a strong correlation and an increased risk for mental health conditions in the CHD population. Particularly, this article or study looked at specifically single ventricle, again, those more complex conditions, but even in the milder ASD or VSD, there can be some increased risk for anxiety, for ADHD, for depression, for PTSD, which tends to be a big one, particularly in the older patients. This is another infographic by Dr. Adrian Kovacs and group, and it is fantastic, honestly, one of my favorites. And it really looks at considerations across the life course, things that we have to consider that could impact mental health or other domains or areas of outcome. And it's sort of to sort of help us wrap around our heads of everything that we really have to consider. Now, Dr. Brosik Soto gave a great presentation at a recent conference back in September of this year, talking about parent mental health and how that also impacts the child's mental health and the child's functioning. A lot of times, anecdotally, I always ask, obviously, about trauma for the child and medical trauma, how that has impacted them. The parents, without a doubt, more often than not, will say, it was traumatic for me. They cannot speak to necessarily whether or not it was traumatic for their infant going through surgery, but it was certainly traumatic for them. And so a lot of them are experiencing PTSD, anxiety, depression. That naturally changes the whole environment that the child is in, right? With a parent being anxious about their condition, the parent might naturally limit certain things just out of abundance of caution. And that can, in and of itself, ultimately impact the child and family relationships and all that. So in terms of research, let's think about past, present, and future, and sort of where do we go from here? I think we can oftentimes in the field, we attribute this scientific statement almost like the Big Bang. It was really groundbreaking at the time. This is back from 2012, Dr. Marino and group. And the vast majority of these individuals are still practicing and still doing research and still extremely important to the field. But this scientific research was the first of its kind, and really highlighting everything that we knew so far from a neurodevelopmental outcome, again, back in 2012. And since then, there's been this giant number of studies really focusing on these kiddos and these conditions. Now, research up until now has had some limitations, as naturally would happen, right? A lot of times, patient functioning is operationalized on IQ. And we know from a neuropsych standpoint, IQ is not the end all be all. I probably venture a guess that for me personally, IQ is probably my least favorite data point or statistic. A lot of times, adaptive functioning and how does that impact the patient outside on a day-to-day, outside of the scope of what we see in evaluations, right? Sometimes those are ignored in research. It's important to be able to capture that. That has been a shift as of late where more and more studies are focusing on that, but early on, that was not the case. A lot of times when a patient presents as having no difficulties or no deficits early on, in research, they're not followed long term. And that's something that also has been changing because, as we know, if a child does not do well on a Bailey, doesn't mean that they won't do well on an IQ measure or later neurocognitive measures later on as they get older. Those two things are not necessarily related. So it's important, even though sort of the reverse, right? Even if a child does well, doesn't automatically mean that they will do well later on. And so it's important to continue to monitor them regardless. Not a lot of studies focus on true big neuropsych batteries. I think just for ease of the study itself. Again, there has been a change in that more recently. More often than not, the comparison groups are healthy controls. You know, what happens when we compare these kiddos to other individuals with chronic condition, whether that be another genetic condition or epilepsy or something that's more chronic. Up until now, there hasn't been a whole lot of studies on adults. And again, that is changing. And like I said earlier, the vast majority of these studies are cross-sectional, not a whole lot of longitudinal research coming out yet. And most recently, to keep up with that, with the 2012 statement, a lot of the same culprits joined together to put together a new scientific statement just this year. This is literally fresh, hot off the presses. And it really talks about, again, 12 years later, what do we know now? And this one really speaks to more about adults and sort of speaking to what do we know or lack of knowledge relating to adults with CHD and all of, and everything like that. Now, in the same cardiac conference earlier this year, Dr. Cassidy also presented sort of what's going on from a research standpoint in the ACHD world. So there was recently an ACHD and neurocognition conference, and all the best minds came together to really understand, put together these 3 working groups and understand ACHD more. Whether that's, what are the neuropsychological or psychological outcomes, what does it look like from a genetics and brain health standpoint, and then what are interventions that are required or best suited for these patients. And so how is CHD monitored? Even early on, all the way through adulthood, and it really starts with the collaboration from various disciplines, and it would not be possible without all of these collaboratives or associations or groups or networks that do 99% of the move when it comes to research improvement and groundbreaking information. Particularly the Cardiac Neurodevelopmental Outcome Collaborative is a fantastic collaborative that has members, institutional members from across the globe. As you can see, the vast majority is here in the States, but we've recently added more. Australia is a very prominent country when it comes to CHD research. They're always pumping out research, which is fantastic to see. And more recently, members in Europe and Asia are all coming together to really talk through worldwide and not just our limited sort of Western view of what's going on. So why is it important to have these clinics? And it really is about how do we care for these patients? How do we improve quality of care? Research has shown that these clinics have significantly lower mortality rates because of that constant monitoring. It's really become the new standard of care. And from us, from a neuropsychological standpoint, it's extremely important because it really helps us figure out at different stages of life, what's going on, help the family understand what's going on, what are the things that the child is doing that's beyond their control and sort of how their brain is functioning. And it really helps guide recommendations across the board. And so in thinking about the Heart Institute here at Cincinnati Children's, we have sort of two big columns, the pediatric side and the adult side, all treating all kinds of congenital heart diseases and defects. On the adult side, there's really not a whole lot of ACHD specific programs out there. Our program is quite large and does a lot for patients across the country with adult conditions, adult CHDs. Now, it all starts from a evaluation standpoint. It all starts early on with our neurodevelopmental and educational clinic. And this is a fantastic group that really looks at the neurodevelopmental aspect of things, school age evaluations, what are the recommendations for school, what does that mean, how is the child doing from an academic standpoint, and really monitors kiddos early on. And then Dr. Kasparian founded the Heart and Mind Wellbeing Center, and it really is an inclusive program designed as sort of wraparound care of mental health concerns for across the lifespan for all of the patients of our Heart Institute. It's a group of treating psychologists, myself as the neuropsychologist, social work, child life research. It's very involved. Now, my service in particular was recently established, and it's specially designed to create care for adolescents and adults with CHD. The NDEC, or that neurodevelopmental clinic, focuses on the little ones, and my job is to really evaluate the adults, older teens and adults. It's really one of the first programs of its kind to be customized for this population in specific. Now, a lot of times my patients will ask me, why? What is the point of seeing you now? I haven't seen you for years. Why should I see you now? And yes, they didn't get that monitoring, which would have been fantastic. But it didn't exist back then, right? A lot of times they ask me, where were you when I was a child? And in my mind, my often answer is probably I was a child myself. This was years ago. But now, we can still provide a lot of resources, whether that be lifelong cognitive monitoring, providing education and career recommendations, looking at the mental health assessment that is very big. Anecdotally, a lot of my ACHD patients have some mental health concerns, more so than cognitive concerns, which is interesting. Very small N thus far, but definitely something we'll be publishing hopefully in the future. We look at social cognition and its relationships, quality of life improvement, the impact of comorbidities like congestive heart failure and things like that, and what does that mean for the patient long term. And so in terms of future research goals, really, I want to understand the long-term impact or the longitudinal impact of CHD, particularly as we get past middle age into old age and things like that. Understand how early cardiovascular challenges shape neurological outcomes over time, whether there are protective factors, whether we look at resilience and vulnerability and everything for these conditions. And so with that, I leave the final slide of any questions. And this is the infamous Heart and Brain comic that is one of my favorites. And yeah, if anyone has any questions, concerns, comments, happy to answer them. Thank you for having me.
Thank you so much, Dr. Schneider. This was absolutely an incredible presentation. I have so many notes. I mean, I learned so much. This topic is huge. It is absolutely huge. And I'm so happy that you're able to provide us about so much information. I mean, from the anatomy to the functioning to the different types of areas neuropsychologists can intervene, even the mental health aspect. There's a lot here. And I know that I'm definitely like one time is not enough. So I know that I'm definitely going to go back and rewatch this lecture on our website and on YouTube as well. And I definitely recommend that to all of our listeners to share that. We do have questions, and I have some specific questions here in terms of something that you talked about was the impact on anesthesia. And like you said, there's so much going on for these patients as infants. Is there anything that you can share in terms of that impact on anesthesia? Is it more acute? Is it more long term? And what that may or may look like, and if we're even involved in that at all?
Yeah, so a lot of times psychologists tend to be more so involved on that inpatient side of things. post-surgical complications or anything like that. They very much have their hands on that. A screener, if you will, from a neuropsych standpoint, can be helpful, but it won't necessarily highlight anything. Naturally, as they're coming off of anesthesia, there's that grogginess, there's that difficulty. So certainly there's that immediate acute impact. But there can be, and where research has focused more so on is the brain tends to recover from anesthesia usually within 6 months. And so 6 months post-surgery, we can expect some sort of recovery or a return to baseline, if you will. But sometimes that does not happen. And so research has really focused on what happens or why are there some patients more vulnerable to long-term impacts, whereas others are not and are more resilient. Is it the age with which the anesthesia event happened, or whether it's the type of anesthesia, anesthetic agent that was utilized. So, research is really trying to understand, what happens long term from there.
That's absolutely fascinating. Personally, I didn't realize that it took 6 months, so that is really interesting to know. And I think when you were talking about the connection between the brain and the heart, you had mentioned that. Let me go look back in my notes. Just in terms of the brain has this constant depletion. So I guess, like you're saying, putting that together with the anesthesia on top of it, you're having this just a mix of effects a mix of variables that just are not good in terms of brain development. In terms of the autism piece, you know, with what we know about autism, there's a genetic component and then there's the neuroanatomical issues. How do you feel like, I guess, how much do you feel like this is the underdeveloped right hemisphere, variable socialization, missing out on those key child aspects, and like a perfect storm of a neurodevelopmental issue and environmental issue interacting? And I guess, what does that, if you have seen that come up in your older adolescence, what you can speak to in that regard?
Yeah, you're absolutely spot on in that it really does become a perfect storm, if you will, that can cause some of these difficulties. And like I said, a lot of times we're finding that even if we see a child with congenital heart disease and are thinking of autism and we're not really seeing a whole lot of concerns and we rule it out, we really cannot ever rule it out, because a lot of times the difficulties, particularly the social aspect of things, come online or present more so for these patients or later on in adolescence. And so if we rule it out and discard it and not consider it in adolescence, then that can be a diagnostic problem. And I'm even seeing some of my adult patients that are complaining about the possibility, see TikTok and the autism TikTok or the neurodiversity and all of these things, wanting to be know, are they neurodivergent and all of that. And so for whatever reason, this was missed for the entirety of their lives. But now as adults, they're almost coming to terms with, oh, do I see this in myself? Is this really happening? And we again should consider it because we more often than not, we can understand the diagnosis or even provide a diagnosis without the need for an ADOS, which is obviously, as we know, the gold standard for it. But just because we sort of put it all together, and if, seeing these difficulties, sometimes the social might not have been happening earlier on, but there were a lot of other red flags, and then the social comes out later. So it's really, we're still trying to tease apart as to what's causing it or why it's happening, or why is there an increased risk for this population, for sure.
So many fascinating things that you highlighted, and something that I thought of too while you were mentioning that is you were talking about the complications and just how many surgeries these patients can have, early on in their life. Who's to say that families are even focused on that in that moment? Like
Exactly.
that, right? They're just worried about their child getting through the next day or getting through the surgery themselves.
Absolutely. And the trauma piece for the parents, right? Like I said
Mhm.
earlier, if a parent is, have that trauma from surgery, oftentimes they will treat their child differently. They will do things more for them than so a parent with a neurotypical child would, right? And so this is why a lot of times, I believe that we can see some adaptive difficulties because for a long time they were catered to, because everyone is almost sort of treating them with sort of these gloves, and making sure that they're okay. But that can be detrimental in and of itself later on down the line if they're not, now they don't have the skill and that needs to come online much later on.
So fascinating, and definitely lots of avenues for research so that we can support these patients and families down the road. And something that you're talking about too, in terms of your clinic being innovative in treating those older adolescents and adults, which is fantastic. It kind of brings up for me this access to care issue. Although I know CHD has been around for a while, but there's new aspects to this area in terms of neuropsychology. But related to that, do you, I'm thinking about access to care in patients who maybe English is not their first language, or and can you speak to any of that and how, if you do see that in your practice?
Yeah. So, being trilingual, I am able to see patients who are Spanish speakers or Portuguese speakers. So from a neuropsych standpoint, it does give us a little bit more access. Now, I don't speak a lot of the other languages of 200 other languages in the world. So there's still a lot of access that's missing. And I think that speaks to the importance of having collaboration across the globe, which is why that CNOC slide was extremely important, because it shows the vast majority of our institutional members are in the States. And so it really limits, it makes our view, our world view of it very narrow. And we assume that every patient in every country, in every corner of the world is experiencing this. That may not be the case, which is why it's important to get the perspective and the data and the research coming from these institutions, in other areas, in Europe, in Asia, in Australia, and all these other locations where their culture might be different. How does culture impact access to care, or sort of what does that mean? In Cincinnati, we have the benefit of seeing patients from all over the world. And so I think that's fantastic, but that not every patient can travel, right? Not every patient from Russia, from Greece, from wherever can travel to the States and come here to be treated. And so it's important for us to collaborate and have that wider understanding of what's going on in those areas for sure.
That collaboration truly is key. Something else that came up, we have a comment here. It looks like one of our attendees saying, so important not to forget the link between parental mental health and that of the child. Yes, I think you definitely highlighted that, and that was so nice to see because we're so fake. Sometimes we can get kind of pigeonholed into the patient, the patient, the patient. But I know as psychologists, we're trained to think about the system. Also, this attendee saying that we see this with neurocognitive deficit outcomes in vertically infected parental mental health, particularly depression and guilt, and that can impact attachment between mother and child. Um, and it looks like there's also a similarity in terms of HIV transmission and neurodevelopmental outcomes. So maybe kind of drawing some connections there between these populations. Um, in the few minutes we have left, I was wondering, you had the slide that talked about the three working groups, but just, in terms of your specialized clinic in general, I was wondering, can you tell us about how your clinic is structured? Like, do you have multidisciplinary aspects? Is it primarily outpatient? Just kind of what that looked like.
Yeah, sure. So, like I said, so the Heart and Mind Wellbeing Center is an interdisciplinary group. We have psychologists that are treatment psychologists that see not only patients and families inpatient, but also at the outpatient level. We can see either there's a fetal caregiver care, whether it's a mother with a newly diagnosed infant or gestation that has the condition. So we might be able to help them and see them. But also even in the adolescents, sometimes parents need that mental health support. So we provide that support as well. Child life. We have a fantastic child life specialist who works with all the families. Social work is very much involved. And then that's where the neuropsych comes in. As of right now, it's 100% an outpatient service. And it's, we have the index, one of our psychologists does the evaluation for the early kiddos, the neurodevelopment, that side of things, school age. And then my services is mostly the older teens and adults to provide more of that specialized care, understand what's going on with them, give them an understanding. A lot of times, in feedbacks I get, I thought that this is how I was. And I was like, yes, that is how you are because your brain developed this way, or because sort of the impact of it all. And I think a lot of my adult patients haven't seen, or the literature wasn't around at the time to really connect the heart and brain. So my role is really to provide a lot of that education, and so that we can all monitor together, provide recommendations, resources, all those things that could be helpful for an adult. Eventually, I think We would love to have that inpatient side of it as well. But we're trying to just cover the outpatient for now.
That's incredible. Thank you so much again for your presentation, for
Course.
taking all these questions and all the honestly groundbreaking work that you're doing clinically and scholarly. We're so happy to have you, and I hope you have a great day.
Thank you so much. Thank you everybody for logging on and watching this, and anybody who watches it after the fact. It's an honor to be here, and I very much appreciate the community and the board for the invite. Thank you.
Thank you. Have a great day. Bye-bye.
Thanks, guys. Bye.